What's up everybody, Dr. Rossi, and today we're going to be talking about a topic that I should have probably talked about a while ago. However, there's been some recent updates, a new FDA-approved medication for one of these disorders that we're going to be discussing here. And I wanted to start talking about it a little bit more in detail, but first giving you kind of a primer on the disorders in general. So when we think about childbirth, when I think about it, anyone thinks about it, we think about it as an exciting time in a person's life, a time of happiness and joy. However, what we fail to realize is many women experience mood symptoms either right before giving birth or shortly after giving birth. Now, of course, those symptoms can range in severity. We can have simple things like the so-called baby blues, which are mild, self-limited symptoms that often go away within a few weeks postpartum. However, we can also have situations where people develop severe disorders such as postpartum psychosis. And these disorders can have significant consequences to both the mother and the infant. Things such as neglecting to care for the infant appropriately, etc. So what we're here to discuss today is postpartum psychiatric diagnoses, and I'm going to hit on some of the points that aren't talked about in all of the textbooks, so stay tuned in the next section. So we should start our discussion with postpartum blues, because this is very common. It often occurs within the first few days or weeks after the child is born, and it can be a difficult time for people, but it's something that you as the clinician would recommend to your patient to just kind of relax. It's self-limiting, as long as the symptoms aren't too severe. So what we're talking about in the case of postpartum blues is we're thinking about mild symptoms that are self-limited. And these symptoms include feeling more moody than usual, crying, feeling more emotional, having some emotional dysregulation, but there are, importantly, no signs or symptoms of clinical depression. So we don't see any signs or symptoms that would indicate that the depression is significantly severe. And of course, there's nothing like suicidality present where the person could be at risk for harming themselves or the newborn infant. Now, this is something that, again, like I said, is usually self-limited. It resolves spontaneously. We would provide reassurance to the patient. We would also maybe recommend something like counseling, brief counseling, secondary, to help the person to work through this difficult situation. And it usually resolves within 2 weeks of onset. Postpartum depression, on the other hand, is a clinically significant depression. It largely consists of the same symptoms that are in the DSM-5 criteria for major depressive disorder, so I'm not going to go through all of those here. They've been gone through elsewhere in other videos, and you can look them up if you're interested. But essentially, the same symptoms of any clinical depression would be present in postpartum depression. Now, it can develop pretty early in the postpartum period, as early as 2 weeks, and again, it's different than the baby blues that we talked about in the last section because the symptoms are much more severe. So we have more of a clinical depression at this point. It's not just some moodiness, some crying, some emotional dysregulation. It's much more significant than that. In the DSM, they have what's called a peripartum specifier, which just indicates that the symptoms have to occur within 4 weeks of delivery. Now, the prevalence of postpartum depression is actually pretty high. It's anywhere from the range of 10 to 15%. So that's a pretty significant number of women who are having a new baby are going to be at risk for postpartum depression. There are several risk factors that you want to be aware of, either as a clinician or as a patient, because these are things that put you at higher risk. The number one factor is going to be a prior history of major depression or a history of depression during the pregnancy or postpartum depression in the past with a previous childbirth. Any of those things, any history of prior depressive episodes or depression is going to put you at higher risk. Another thing that puts you at high risk is having stressful life events. This could be death of a family member. This could be other factors, housing insecurity, food insecurity, etc. The more stressors you have, the more likely you are to develop postpartum depression. Conflict with the baby's father and or your partner, those things are going to be concerning because that's also going to put you at higher risk for developing postpartum depression. And of course, things like financial issues and socioeconomic status will also put you at risk for postpartum depression. Now, 25% of women with a history of depression are at risk for developing postpartum depression, and if they had postpartum depression in the past, it's even higher than that. So we really want to focus on that prior history of depressive episodes or postpartum depression in the past as significant risk factors. Let's talk a little bit about screening for postpartum depression. So everybody who delivers a baby on the OB floors will be screened for postpartum depression. And this is actually one of the more common reasons for me to be consulted to the OB floors to evaluate a patient. And this will be triggered automatically whenever somebody has a really high Edinburgh postnatal depression scale score. So a score of 14 or higher is usually a good indication that the person has postpartum depression. So everyone receives this screening scale. It's a 10-question scale that's very easy to fill out. It's validated across cultures as well as available in multiple languages. So this is the way in which a lot of hospitals will screen for postpartum depression. Let's talk a little bit more specifically about symptoms associated with postpartum depression, because as I said before, they are largely the same criteria as those found in the DSM-5 for major depressive disorder, but I do want to highlight a couple of important differences or unique things that you can see in postpartum depression. So there's often a high degree of anxiety in postpartum depression, so this will be a very anxious type of depression, and there will often be obsessive thinking, almost similar to obsessive compulsive disorder type of thinking. Interestingly, obsessive compulsive disorder has been associated with oxytocin levels. And one thing we know about pregnancy is that oxytocin spikes during pregnancy and is associated with maternal behaviors such as, of course, obsessing about the safety and care of your child, or newborn infant rather. When these behaviors are taken to extremes though, they can cause significant functional impairment, which is going to be a problem for the mother. There tends to be a little bit less risk for suicide in postpartum depression. It's about half of that of depressions that occur at other points in a woman's life. Postpartum depression is common, and most women recover from postpartum depression completely with treatment. So one of the things we need to do as clinicians is we need to provide reassurance to these individuals that there is adequate treatment for postpartum depression, that most people recover fully from it, and that it does not make you a bad mother or a bad person for experiencing this depression. So it's very important that we communicate those things effectively to our patients and that they understand that there's a very good chance they're going to get better. What are the adverse consequences of postpartum depression? Because this is very important to know what could potentially happen if postpartum depression is not addressed appropriately. So it impairs the mother's ability to care for the infant, which is very critical at that stage of development. It's associated with things like poor nutrition and poor health of the infant. It interferes with maternal bonding. It will interfere with the ability to breastfeed, and it will interfere, of course, with the relationship between the patient and the partner. It's associated with other things that are critical to the infant as well, direct implications here being abnormal development, cognitive impairment, and psychopathology in the infant. So the identifying, treating, and working with patients with postpartum depression is going to be essential to avoiding some of these adverse consequences. So we should talk a little bit about postpartum psychosis. Although not typically a part of postpartum depression, it is something that can occur, and it is probably the most severe of the illnesses that we are describing here. Now, this is a very dangerous illness with a rapid onset. One day you can be talking to the person and they're having a logical, goal-directed conversation, and then the next day you see them on consult and they're grossly psychotic, unable to hold that same logical, goal-directed conversation you had with them 2 days ago. Now, the number one risk factor for somebody to develop postpartum psychosis is going to be the diagnosis of bipolar disorder. So in women who have bipolar disorder who are pregnant, often the pregnancy is a protective time. Pregnancy itself is protective, which kind of makes sense from an evolutionary standpoint. We would not want the mother to be having manic episodes while she's pregnant, correct? At least that's what I would think. Anyway, regardless of why this is, pregnancy is often protective for those individuals. However, the postpartum period is a very dangerous time. This is a time where things like sleep deprivation can become a major issue and can trigger manic episodes and or psychosis. And that's what we find ourselves talking about here. Now, the main concern, of course, of a postpartum psychosis is the delusional thinking that's often associated with the illness. And the reason that's a problem is because many of these individuals will have the infant as part of the delusion. And that's a big issue. This can lead to problems. This can lead to mothers refusing to take care of the infant, secondary to the delusional thought process. It's important to have good family support at this point because this is where the family is going to need to take over care until the mother is through this episode of psychosis. Okay guys, so to wrap things up here, I'm going to say that postpartum mood changes are very common, and they can range from mild symptoms such as mild moodiness and irritability, all the way up to postpartum psychosis, which is very severe and dangerous illness, like we talked about in the last section. It's important to reassure the mother and the family that this is not a failure on the mother's part. This does not make the mother a bad person or a bad mother to the newborn infant. We want to provide a lot of reassurance that with treatment, majority of cases resolve, and this is true from what we know in the literature. Most cases of postpartum depression resolve completely with treatment. We want to keep in mind that a history of prior major depressive disorder or prior postpartum depression will make the mother vulnerable to developing future episodes of depression should they become pregnant again. We also want to keep in mind that bipolar disorder is a significant risk factor for the development of postpartum psychosis. So with that said, guys, I'm going to hold the video there. I'm looking forward to your comments and questions below. Please drop them in the comments section, and please like and subscribe to the channel because it really does help me to keep this thing going. Thanks again, and I'll see you in the next section, where we'll be discussing the FDA-approved treatment for postpartum depression.